But anyway, when I was called, they said, well, tell us about single payer. So the first part of the talk is going to be about single payer, the various systems of single payer, and how that may or may not fit into the U.S. But then I have another section. I imagine y'all are kind of interested about what we're going to be doing, or trying to do here in Idaho. So I have a section on the Idaho healthcare plans. It's a double waiver that has been submitted to CMS and to Your Health Idaho, or I'm sorry, healthcare.gov to have a waiver on the insurance side and on the Medicaid side. And then be happy to answer any questions I have. I want to acknowledge a couple of my former compatriots, Shirley Ringo, who bugged me for years and years. A fellow that I kind of walked side by side with for years, trying to get Idaho to do what's right with healthcare, Dr. Dan Schmidt. Trying to take care of the citizens of Idaho. So anyway, let's just get started. This is a kind of a sizable group, but I'll take questions as we go, as long as they're flowing into part of the presentation, and then I'll stay as long as you want to answer questions afterwards. So let's go with the first slide. We're going to talk about single payer, what that means, and I might have to get back here so I can see my own slides. So there's a lot of different models on what single payer is, but basically it means that one entity, usually the government, pays for health care for all of the residents. That allows a lot of power. You can set the standards, the clinical standards. You can set the administrative standards. You can set the definition of what's covered under a policy. You can define when something is no longer experimental, but rather is standard of care. And you also can say, okay, if we're going to have a new service, it has to meet these standards of effectiveness and efficiency. And those are things that have really been very useful in other parts of the world. Needless to say, we don't do that here. The other, there usually is an opportunity in many of the single payer systems to purchase private insurance outside of the system. Not always, but most of them have that. And as you might imagine, if there's only one purchaser of health care, they have a pretty good handle on how to control the cost in negotiations. So, next slide, please. Okay, so I'm going to talk about a few different models around the world, and then talk about what we do here. The Bismarck, or German system. This came about under Otto von Bismarck in the start of the 20th century, as they brought the German various political units together. And it is basically a insurance system. But it is heavily regulated by plans that are not for profit. And they have standard administrative and clinical guidelines that they do. And this is something that's seen in Germany, France, Belgium, Netherlands, Japan, kind of the European, Switzerland, and to a great extent in Latin America. There's the Beveridge model, or the British model, which the government runs not only the financing or the paying for healthcare, but also owns or runs the delivery system. Now, if you think about it, why did that happen in England? Well, during World War II, two things happened. There's a lot of bombing, and hospitals and cities were part of being bombed, and they moved a lot of the population out into the rural areas where there was no health care. So the government, as part of the war effort and after the war effort, had to set up a system of care. Physicians, clinics, midwives, hospitals, etc. And so the government set up the system and owned the system. But they also had the financing part of it, because it came through government financing. So the government runs not only the financing, but owns or runs the delivery system. or a significant portion of it. Now, Great Britain, of course, is kind of the prime model of that, but it's also Spain. Most of the Scandinavian countries are like that. Hong Kong and Cuba. Okay.
I'm Australia.
There's an entity, nationalized health insurance. The providers, the doctors, hospitals, clinics, pharmacies, etc., are all private entities, but there's a central budget and financing. And that's kind of the way it is in Canada. Each province has its own budget. They get money from the federal, from their national government, and then they have a budget for each province, and that budget then is divided between the various providers in a negotiated process. So the financing is centralized to one entity. Whoops. She's a little trigger figure there. And even though there are private delivery. Canada, of course, is the one we're all used to, but Taiwan has a system that has gone that way probably over the last 12 years. And South Korea is similar to that as well. So, let's talk a little bit about the different models and what's good or...
Quick question then.
Sure.
So the individual provinces set the budget for the health care after they get money from the federal government?
Right.
Okay.
It's set on a provincial basis.
Okay.
Now,
The
I
province
think
itself-
they have some basic standards that they have to cover, but how much they pay, that's the negotiation between the providers, organizations, and the provincial government in Canada. Okay, next slide. And of course, there's the good old American system. Premiums are where there's premiums collected by insurance company from both policyholder, the individual, and the employer. There are methods, cost devices in there to lower the cost of the premium, and that includes co-payment, deductible, medical management, decisions, etc. There's usually, since it is a privately run and minimally regulated activity, there's a lot of carriers. Many are for-profit. In fact, many of what used to be not-for-profit, Blues, have converted to for-profit, and now are available on if you want to buy in on a stock market, on the stock exchange. But because there's so many, they really have limited negotiation. Nobody has a big enough piece, except Medicare, to really have much of a power in negotiation. And that's really, if you think about it, and it's not so much around here, but it is a little bit, think about all the consolidation in healthcare. You know, you go to the Portland area, whereas there used to be a bunch of hospitals, now there's probably, what, 3 systems? In Spokane, there's 2. Boise, there's 2. Many other places, there isn't even 2. So consolidation on the provider strengthens their negotiating position, and it weakens that of the multiple insurers who don't negotiate collectively. It is most complex and administratively costly because each of the different states, each of the different insurance companies has their own rules of how they want things handled. They have their own systems, and as a result, you oftentimes get as many administrative people in the billing department as you do in caregivers. Now, they're probably not paid as much, but there's still a lot of them. And interestingly, it is a model that people go to first when they develop a healthcare system. And it's what you see in low GDP or in developing countries, except the United States. Okay?